Good morning, everyone. I am Dr. Nidhi Agarwal, and it's my sincere pleasure to have you all participate in this first strabismus surgical workshop here at SSCI. We are gathered here to encourage some collaborative learning experience, and our principle is that if your basic understanding is good, then we can easily understand this complex subject. So, in my personal experience as a resident, I did not have much exposure to strabismus. And now that I know strabismus a bit, so it makes me wonder that with all the 6 muscles in each eye, what all can you treat? You can treat a simple case as well as you can treat a complex case. I will strongly encourage all of you to ask questions, be how much ever basic it is, because this discussion, this workshop is for the residents primarily who are yet to learn their basics.
Very warm welcome to everyone. Thank you so much for coming. And the idea here is essentially to give hands-on training in a form of workshop to all the residents, and also to enhance your skills for those are already well versed with strabismus surgery. But however, remember one thing, that strabismus was always dreaded as a subject in our residency days, and whether the eye is in or out or up or down, it's very difficult to say, because what you see up is down for someone else, what you see in is out for someone else. And it's a rule that there is no single right answer in strabismus. But however, yes, the workshop is important, the hands-on is very important. Knowing your skills is important. The most important part of any strabismus subject is to know the clinical evaluation and to have the correct diagnosis so that you have an approach. It's like a mathematical concept. It's like your derivatives and integrals, what you had in your younger days, where there are multiple solutions to a single problem, but you must identify the problem first. So we are going to very quickly go through the evaluation, and I've tried to make it as simple as possible, and let's see I'll be able to convey through this next 10-12 minutes of presentation. So we are going to focus, of course, on clinical evaluation only. I will not go into the simple and complex kind of strabismus. This is essentially what you need in a clinic. This is the basic bare minimum. Apart from your visual acuity, your refraction, this is the specific set of. And of course, you can replace the loose prisms or the prism bar, but this is enough for your complete clinical evaluation to know the motor and sensory evaluation of strabismus. What is the state of the patient? That's it. So what are we going to focus on? We are going to focus on these 5 things very quickly. The most important things of these 5 points of any clinical evaluation is the extraocular motility evaluation. Once you do that, and that should be the first thing what you do in any patient when you are evaluating a patient with strabismus, it gives you a diagnosis there and there itself. That what are you dealing with? Where exactly and you can actually predict what would be the deviation in particular gaze. What do you expect? So motility, carefully, because we go very fast in motility, thinking that okay, next step is more important, where we measure and we want to do that surgery. But motility gives you a very lot of information. So that is what I'm going to focus on more, and then cover the light reflex test, the cover uncover test, the prism bar, and the sensory evaluation. Of course, this everyone should be well versed with. When you're looking at the eye in all directions of the gaze, or the cardinal positions of the gaze, what we say, you must actually imagine the muscles moving in that direction. Which are the yoke muscles which are moving, which are the yoke muscles which aren't moving, which are overacting, which are underacting. So that imagination when the patient is front of you makes things quite simple. So you must know their primary, secondary and tertiary action. This should be engraved in your mind before you go. Motility is not that simple, and it's something where in your practical examination as well as practically in the patient, that when you're looking at, you may do it unknowingly, but it should be there that you must check ductions and versions separately. What do you mean by ductions and version? We'll see with this upcoming examination. So when you're looking at ductions, you are essentially doing a monocular testing, remember. You are just looking at a single muscle at a time. So when the gaze is left to right or right to left, you are essentially looking at the medial and the lateral rectus. When you are looking up and down, you are looking at the superior and the inferior rectus. That's all. You are not looking at what is happening to the other eye, and you are doing this individually for either eye. So this is purely ductions. Now, why this was important? Why did I focus so much on it? So quickly, one of the residents, what is happening here? The photograph to your left, the up and down. What do you see? What do you see? You see here something, you see here something. What do you see here? This is the straight gaze. This child is looking in the right gaze. In the left gaze, sorry. So what do you see here? There is limitation of, who said that? There is a limitation of abduction. And do you conclude with this? You want to do something more to confirm whether there is abduction limitation here? So the child, of course, has an inward deviation of the left eye here. Child is likely fixing. It's a dilated photograph, so not the ideal. But when you are looking at one of the gazes in the left gaze of the child, you see there is abduction limitation. Go back to your abductions. Full motility the child has. Okay, this is because of the phenomena called as cross fixation. Here the child is using this eye to fixate, and that's why you see this pseudo limitation or the apparent limitation. Yeah, it's not a 6-nerve palsy. Very one simple test, just close one eye and you'll get the finding. So that's why the importance of duck. You may be doing it, but you may not be actually doing it all the time. So it should be in the back of your mind that what you are looking at. In infants, you may not be able to always do. So a very quick maneuver is the Dolce maneuver. Of course, Dolce maneuver is also intact. It tells you about the supranuclear pathway also, because it's a supranuclear phenomenon. So you turn the head in that direction when you have a restriction. Now, never use the word restriction in your exam because it is limitation. Restriction diagnosis comes later when you're looking at an actually restrictive form, whether it's thyroid eye disease or whether it is some trauma or there's entrapment or muscle is fibrous for whatever reasons. The term restriction should be restricted in your practical examination. You lose the term limitation, and because it could be palsy or it could be restrictive strabismus, paresis or restrictive. So don't use that. And Dolce gives you a clear motility. It does not still tell you whether there is limitation or not, but it tells you, okay, supranuclear pathway is intact. There is no restriction in this particular case. That's all. So what are the cardinal positions of the gazes? How many cardinal position of the gazes we have? 9. We'll go with the 6 cardinal position of the gaze. When you say 6 cardinal position of the gazes, because you don't look elevation and depression as one of the factors. You look at the dextro elevation because you get all the muscles. So when you're looking at dextro elevation, you're looking at SR and the IO. Look at those letters which are jumping. So that is the muscles which you are looking at, yoke muscles. So in dextro depression, you have the IR and the SO. Then in levo elevation, you have the IR and the SO of the right and the left eye. Of course, this is not something which you might be able to immediately pick it up, but you must go through this again and again to understand what you are looking at. Of course, during the left and the right gaze, you have the yoke muscle of the lateral rectus and the medial rectus. This picture should be in your mind, that which muscle here is dancing, which muscle is acting. So it tells you a lot of things. If you see under action, over action of the muscles here, you may come to know, okay, this is what I expect in that direction of the gaze when I'm going to measure, or this is the likely diagnosis. There is limitation of one causing overaction of the other. So how do you now, we saw how do you assess. Now we are going to quickly see through how do you evaluate, or how do you actually document, and what is the grades of limitation. If I just say there is abduction limitation, is it enough? It is not enough, because we want to know the grade, because today it is at particular grade, tomorrow it is improving or worsening is some information you want to know over the period of time. Many methods have been described as gaze. A very simplistic method, you can use a scale in your clinic, or you can use actually your trial frame to evaluate. But the trial frame has to be a little bit bigger. You can't use a pediatric trial frame on an adult because you will not see that limitation. So eye movements which are limited by these many percentages, and by these many percentages, use a reference point. Look at the temporal limbus is touching just the lateral canthi. If it is just not touching the lateral canthi, then there is about 25% limitation here, grade -1 limitation. 50%, it's still going beyond the midline. There is still movement of the globe beyond the midline. Inductions, remember, all these are ductions, not versions. Then you have a -2 grade limitation. You have -3, where it is just going up to the midline, just going beyond it, but just stopping there. -3, and the eye is just moving up to the midline and not going beyond the midline, is -4. Everyone has a different grades of doing it. So the best thing to do is a photographic documentation. This I find very easy because I have an anatomical landmark. I look at the temporal part of the limbus and how much it is moving in that direction, and I grade it accordingly. When you have different ways to do it, and everyone has it their own way. Same thing for the adduction. You have the nasal limbi here, which is the 3 o'clock, which is the 9 o'clock position, whether it is touching the puncta. That's your anatomical landmark. You may see an overaction here in certain cases. Again here, how much percentage of limitation is there? You grade it as -1 to -4. The second is the oblique muscle overaction and the other action. So again, a lot of authors right from last 150 years have described various techniques. Von Nuden was a pioneer. Kestem was the pioneer on limbus motility testing. So you have the overaction, over elevation and depression. So what is inferior oblique overaction essentially is What is inferior oblique overaction essentially? What do you notice in inferior oblique overaction? Elevation in adduction. Elevation in adduction is inferior oblique overaction. One simple thing you would want to see in elevation in adduction is what one clinical test should be there to ascertain that this is an inferior oblique overaction. The eye of your interest should not be the fixing eye. So ideally, you must put a cover in between. So this eye should not be, if inferior oblique overaction is what you want to look at, this eye should not be the fixing eye. The child should be fixing with the fellow eye. Then only you will be able to elicit the overaction. Otherwise, this is the fixing eye. It's not going to elevate it because it is a reflex. Inferior oblique overaction, primary inferior oblique is a reflex. So you don't want it to be the fixing eye. So always place a hand over the nose. Don't allow that eye of your interest. Same thing if you want to look at overaction in this of this eye and tell the child to look in the opposite gaze. Again, that eye should not be the fixing eye. So one clinical pearl here, the fixing eye is not the eye where you look at inferior oblique overaction. It is a non-fixing eye where you look at the inferior oblique overaction when you are trying to check the over elevation in adduction. Similarly, over depression in adduction, what is this? What is this? In adduction, there is over depression. It's exactly opposite to the previous picture. So what is this happening? Go back to your muscle, how do they act, the actions of the muscle, the primary and the secondary action. What is the secondary action of the superior oblique? Depression in adduction, so over depression is superior oblique overaction. Again, should not be the fixing eye. So if your target is the, one of the other nomenclature for the superior oblique muscle is also called as a copycat muscle, because you tend to copy from your peers and you're trying to look down and to the left or right, and that's the superior oblique which is overacting. Okay. More objective method of assessment, always do a fundus evaluation. Fundus photography, of course, if available is best, but a very careful, you may not be able to notice on your slit lamp biomicroscopy. So because you want that area where you can judge the position of the disc and the macula or the fovea in this case. And if you see excyclotorsion and intorsion, you correlate with your inferior oblique overaction and underaction. So remember, objective and subjective test may not match. That is not mandatory. But however, to confirm whether clinical evaluation suggests of inferior oblique overaction, you want to double confirm it with your objective assessment, whether there is excyclotorsion, because excyclotorsion is a primary action of the oblique muscle. The secondary actions are the elevation. So you may not have a primary excyclotorsion. Head posture, again, very important. Always examine, gives very clue to diagnosis. Remember the rule of thumb. If there is a face turn, there is horizontal muscle involved. If there is head tilt, there is oblique muscle involved. And if there is chin up and chin down, there is vertical muscle involved. I will take 20 seconds. I know I'm running out of time. So we are going to go with the prerequisites of the cover test. What are the prerequisites? Ability to fixate the target. That's important. Visual acuity should be 20/200 or better. If you have worse visual acuity, the patient is not going to fixate. You will not be able to perform a cover test. There should not be no gross motility defect. Again, very important. If you don't do your motility evaluation, straight away start doing cover, the patient is not able to fix it at all, has -5 motility limitation. How is the patient going to take up fixation in the fellow eye? So again, important, and should have central fixation. Whatever you are measuring is when the eye takes a fixation from a non-centric area to centric area. That's what the prisms are measurement. There is a completely different calculation for eccentric fixation. When you have this drag, macular drag, you measured and it keeps on piling up, and then you see a fundus examination, you see the child had APROP before or the child had ROP before when it's causing a disc and macular drag. There's our eccentric fixation. So I've tried to simplify this cartoon, hope it works, and that's the last part of it. So Hirschberg's corneal reflex test, first thing. Okay, and you see it is centrally placed on the pupil. There is a small nasal deviation, of course, because that's the general anatomy because of the angle kappa. What's the next step you do? You cover one of the eyes. You see eye under the cover. Is it taking any fixation? Is it going in or out direction? Okay, you uncover it. This is your uncover test. So what do you say in your uncover? The eye takes a fixation from out to in or in to out. So basically an intermittent exophoria. Phoria is which is latent, not manifest. Or you can say intermittent exotropia. They both interchangeably can be used because one is manifest sometime, one is not manifested sometime. What is the step 3 is an alternate cover test. So you cover in one of the eye. Okay, the eye under the cover, we don't know what is happening. When you uncover, you see the eye takes a fixation from out to in. Cover the opposite eye. Eye under the cover again goes from out to in, and do this alternate cover test. So we know there is a now intermittent exophoria because the HBT was central, and the eye under the cover, when uncovered, takes fixation from out to in. Right? So when eye under the cover is taking fixation right to it. Now someone will tell you what is the measurement. How much amount of phoria or tropia is there. How do you measure it? place a simple prism, okay, of appropriate degree. You calculate it based on how much prism is there. There are certain calculations available based on the HBT. Of course, we don't always follow that. If there is a 7 degree of HBT, then you choose a prism, multiply by 2, prism of 14, 28, so on. You can start that judgment you'll get over the period of time. You can start with 15 or 20 prism diopters of prism, and then you see whether eye is still moving or not. It's going in opposite direction. So you increase up the prism or you decrease the value of prism. Then you do a prism counter till you neutralize. What is the end point of neutralization? I would prefer when there is a 5 prism of reversal. For me, that is my end point of neutralization. For some, it is just neutralization where the eye does not take up any fixation. So you put a 30 prism diopter in this, you do an alternate prism bar cover test, and eye takes up no fixation, that the patient has a 30 prism diopter of intermittent exotropia or phoria. That is what the diagnosis you need to make. You cannot usually say a right eye or left eye unless you have a restrictive form of strabismus. It's usually, no, both eyes also. Just intermittent exophoria or tropia, and which is the eye, which is the dominant eye or which is the fixating eye, which will come to know in sensory part of evaluation. Again, Hirschberg corneal reflex test, cover test, uncover test. This is a constant. Eye takes a fixation from out to in. Now, what do you do for modified Krimsky and Krimsky test? Let's say there is a gross motility defect. Patient does not have central fixation. Patient has eccentric fixation, and the eye is not able to fix, or visual acuity is worse than 2200. Patient cannot read your vision chart at all. So you do something called as a modified Krimsky test. You throw a light at the glabella, you see the Hirschberg corneal reflex. You see the corneal reflex is not central on this side. So you place a prism in front of the fixing eye. Fixing eye is the modified Krimsky. What happens to the non-fixing eye? It will take up the fixation. Remember, there is still Haring's law in play. So you shift the image, the fixing eye shifts, the other eye also shifts. You neutralize till your Hirschberg reflex test is center. So this patient has a 30 prism diopters of exotropia or based on modified Krimsky test. Now you have both the eyes where there is an issue. You do not have a fixing eye at all, or you have a gross motility limitation, and the other eye and the fellow eye is also not taking up fixation. You have such situation, or both eye has a -4 limitation with large exotropia for some reason. You put the prism in front of the non-fixing eye. What happens to the corneal reflex? The corneal reflex starts shifting depending on your prism and becomes central. So this is a Krimsky test. Krimsky test placed on the non-good eye, modified Krimsky test placed on the good eye. Simple so far, quite clear. Okay, Nian, you have a paralytic eye and the non-fixed. So this eye does not move. It stops here. So there is a -4 limitation, and then you have a normal fixing eye which is moving quite well. Primary deviation is where eye under the prism is not the fixing eye. So the good eye is fixing eye. When you put prism, the eye under the prism does not take fixation. So the non-fixing eye, this is the non-fixing eye. Is this the normal eye? This is the normal eye. So this is primary deviation. This is very important to measure. And this is also a common question in your exam. What is the primary deviation, secondary deviation? You place the prism in front of the bad eye or the paralytic eye, and the good eye takes up fixation. That is primary deviation. When you place the prism in front of the good eye and the paralytic eye takes up fixation, that is a secondary deviation. Secondary deviation is always more than the primary deviation, because here now the paralytic eye is going to take up fixation by Haring's law. Because there is less innervation, there is going to be more innervation to the fellow eye, and you are going to have a larger angle of strabismus. This is very important because you want to manage certain types of strabismus surgically in a different way. So last 2 slides, sorry. This prism is how you hold it, but there are many ways of holding prism. Most of the prism which we are holding is what we have in the clinic, I presume, are plastic or the fiber-based prism. We no longer use glass prism, which are used in UK even still. So there are 2 positions, the Prentice position and the frontal plane position. And the frontal plane position is the one where the prism always stays in the frontal plane. So supraorbital rim, the prism always stays parallel to the supraorbital rim. These are small nuances, but makes a lot of difference. Your measurement in other gazes, in up gaze and down gaze. So these are very important. So when the patient is in up gaze and down gaze, or is going to move his head by 25 degree or 30 degree up or down, your prism has to move with it. It will always be parallel to the supraorbital rim. Unlike the Prentice position, where it will be always parallel to the gaze. So that makes a lot of difference. The angle of the prism changes. When you are piling up prisms, it makes a lot of difference. And here is where loose prisms have an advantage over the prism bar, because you may not be able to tilt the prism bar that easily how a loose prisms will be able to. When you pile up prisms, there is a geometric addition. So 40 and 40 is not 80. 40 and 40 is 88. So again, your outcome changes if you're not considering all this into your measurement.
Presentation with a small note. These are few sayings which you come across in classic books like Kushner, where it was considered in the Roman era to have, it was a gift to have crossed eyes because you look like a god looking many ways at one time. And if you had crossed eyes, it was considered that you had higher chances of getting a job, It was called a traveling eye. So on the contrary, from that era, we have moved to an era where we are advising early surgical correction of strabismus. So squint is, as you all know, is basically misalignment of the eyes which leads to loss of binocular vision. There are many non-surgical methods. Surgical correction is advised not in all cases, essentially in only certain cases, and in this presentation, we are going to look at those cases. So what are the basic aims of doing a squint surgery? It is to restore the ocular alignment, improve the binocular single vision, eliminate a head posture, enhance the cosmetic appearance, prevent suppression, amblyopia, and alleviation of diplopia in certain cases. So what are the general indications? Whenever you see a patient walking in, you want to know whether is this the patient whom I can surgically, whom will need a surgical intervention or whom you can manage conservatively. So any persistent deviation which is not correctable by conservative methods needs surgery. Very large angle deviations do not go away on their own, they need surgery. When there is symptomatic diplopia, any restrictive or paralytic strabismus after the observation period, and improvement of binocular function in certain cases. So going by specific entities, so in esotropia, any large angle deviations, exotropia, whenever you feel it's there is a loss of stereopsis. In vertical deviation, basically diplopia and anomalous head posture is the indication, and in paralytic squint, again cosmesis and improvement of binocular single field of vision. So what about the timing of the surgery? When should you operate these cases? So on a general note, in infantile esotropia, 6 months to 2 years is what we consider. In any acquired deviation, we wait for 6 to 12 months for spontaneous recovery. And again, the similar in paralytic squint, we wait for 6 to 9 months for recovery. And later, in secondary and residual deviation, as soon as the deviation is stabilized, we operate. So some contraindications are there. Definitely untreated amblyopia, unstable deviation, we shouldn't be operating. So what do you do in a preoperative assessment? First thing we always do is a correction of the refractive error. Treat amblyopia, do the binocular vision assessment. Measurement of the angle of deviation is very important. At least you should have 2 stable measurements which are more or less equal within ranging between 5 to 10 prism diopters. Only do a detailed ocular motility evaluation to see if there is any pattern, and then assess the general health and fitness for anesthesia. So now we just go according to the case wise, so that it's better to understand. So this is a patient who presented with acute esotropia since childhood. She had cross fixation. She had equal vision in both eyes. As you can see, she has inferior oblique overaction. So this is a constant deviation present since childhood with inferior oblique overaction, free alternation and cross fixation. What do you think is the diagnosis? What kind of esotropia is this? So it's a case of infantile esotropia where spontaneous resolution is unlikely. We have to operate as early as possible to achieve at least peripheral fusion. So here the deviation is, once you understand that the deviation is constant and stable and there is free alternation and you have corrected any underlying hyperopia, so do a surgery which usually includes bimedial recession with weakening of the inferior oblique. So this is the second case. You can volunteer. Even if it's wrong, you can actually tell the diagnosis. So this is a 4-year-old girl who came with acute onset of esotropia. This is a constant deviation. Again, equal vision in both eyes. We did a neuroimaging which was normal. So she had around 40 prism diopters of esotropia. What do you think is the diagnosis? And she had diplopia.
Mic behind if anyone wants to answer.
Any volunteers? So this was the case of acquired comitant esotropia, where the onset is in first few years of life. Again, they do not have significant refractive error. Usually they have good alternation. And once you rule out an underlying CNS lesion by doing a neuroimaging, which could be the cause like hydrocephalus or a intracranial tumor or a Chiari malformation, once you have ruled out, you advise surgery, which is again a medial rectus recession. So this is a case of acquired comitant esotropia. Any volunteers? This is the photo sent by the parent on a day, and then this is the photo. This is a photograph taken on a day. So patient has a non-strabismus phase and a strabismic phase. So what kind of esotropia is this? Okay. So this is a case of cyclic esotropia, which is a kind of acquired esotropia seen in 2 to 6 years of age. So they have a strabismic phase and a non-strabismic phase, and which usually lasts for a period of months to years. And once you can do the surgery, once you ruled out underlying hyperopia and myasthenia gravis, you can operate on the angles which you do see during the strabismic phase. So this was a case of cyclic esotropia. So this is another child who had a refractive error of +4 in both eyes. Despite wearing glasses, she still has, what does she have? What does she have? Yeah, she still have an uncorrected deviation, right? So this was a case of partially accommodative esotropia, which also needs, you have to operate over and above whatever is the angle remaining, you have to operate for that. So in fully accommodative, where the glasses correct the strabismus, there is no indication of surgery. But in partially accommodative, you have to go for surgery. So this is a patient who had a macular scar in the right eye. And what does she have in the right eye? What deviation is that? What is the deviation here? So she has a esotropia and she had a macular scar. So this was a case of sensory esotropia where because of an underlying poor visual function, the eye is deviated. So you can operate this at any age. So these could be the most common causes: cataract, corneal opacity, optic atrophy, scar. So surgery gives good results, but always explain the chances of recurrence are high because of poor vision. So coming to exotropia, this was a patient who was a 24-year-old male who had squinting since childhood. So this, as you can see, it's a very large angle. He had around 60 prism diopters of exotropia, again freely alternating. So this is a case of infantile exotropia, which has very poor fusional control. You can see the angles are quite large. So many a times you can have craniofacial anomalies with this kind of exotropia. Again, here surgery is the treatment of choice. So this was a patient, 25-year-old who had who presented with exotropia intermittently. So as you can see, this is again a large angle exotropia which was poorly controlled. So it was an intermittent divergent squint with poor control. So what are the indications of surgery in intermittent exotropia? Loss of fusional control, increased frequency of the manifest phase. When you document that patient has started suppression in either eye, or you document that there is a decrease in stereoacuity. So the other intermittent divergent squint which usually goes on to require surgery is the one with V pattern. As you can see, as Janil just described, this patient had a V pattern, you can see, with the inferior oblique overaction. So coming to vertical deviations, so this was a girl who complained with intermittent drifting, upward drifting of the either eye. What can you see in this? What has happened here? So there was an intermittent drifting of the both eyes, more prominent in the right eye. So this was a case of dissociated vertical deviation. So when do we operate? We do not operate all the cases, only when it's increasing in frequency, when it is associated with the head posture and large, when the phoric face is manifesting. So as you can see, she also had inferior oblique overaction, so she underwent inferior oblique weakening. So as you can see, this is another case where you can see that there is deficient elevation in adduction alone. So this was a case of Brown syndrome. And when do you operate? You do not operate all the cases, only when there is primary gaze hypertropia or it is associated with the anomalous head posture. So coming to this patient, what do you see here? What is wrong with this patient? There is complete loss of abduction in the right eye. So this was a patient of sixth nerve palsy associated with Mobius syndrome. Such cases, acquired cases, you generally wait for 6 months to stabilize, and once the deviation is stable, you do the surgery. This is a patient, this was a male who had a midbrain infarct and deviation following that. So as you can see, there is loss of ptosis, loss of adduction, elevation and depression in the left eye, and also elevation in this was a case of nuclear third nerve palsy. So all such third nerve palsy, surgical plan varies depending on your findings, and do not operate till you see the stability of the deviation. Minimum 6 months you are supposed to wait. Then coming to this patient, she had an anomalous head posture, and as you can see, there is limitation of adduction with severe globe retraction in the left eye. So this is a case of Duane's retraction syndrome. Yes, we do not again operate all cases when there is a large HP, primary gaze squint, and unacceptable upshoot, downshoot, severe globe retraction. Those are the indications for surgery. So this is a case of a child. You can see the child has a chin up with total elevation deficits and eyes are totally down, which is hypertrophy in both eyes. So this was a case of congenital fibrosis. When do we operate? Intractable hypertropia and large chin up. So the next case is a 5-year-old which presented with ptosis and elevation deficit, which is uniform in adduction and abduction also. So this was a case of MED. Once you treat the underlying refractive error and the amblyopia, you operate on this children. So surgical correction is indicated when conservative methods fail. So early surgical planning can give rise to successful outcomes. So these are some of the books which I generally recommend students to read. Kenneth Wright and Von Noden are good. Thank you.
A very good morning to all. At the outset, I would like to thank SSCI team for inviting me. So I'll be presenting an interesting case from EXO to EXO, tail of a slipped medial rectus muscle. Special thanks to Dr. Chandesh Parekh sir for his help and guidance in this case. So we had this 24-year-old female who was a nursing student working at Nair Hospital who presented to our OPD with complaints of face turn to the right side and outward deviation of the left eye since 15 years. There was no history of any ocular trauma, diplopia or any glass use. Parents gave history of inward deviation of the left eye since birth, for which she was operated 9 years, at the age of 9 years elsewhere. All surgical records were not available. Post-operatively, on day 1, the parents noticed outward deviation of the eyes, for which no surgical intervention was done thereafter. So on examination, she had a vision of 6/6 and 660 in the left eye. Anterior segment examination, there was a mild exophthalmos, increase in the palpable fissure height in the left eye compared to the right. There was an inferior nasal conjunctival scar which was seen. Posterior segment examination was normal and she had a right-sided face turn. So this was the 9-gaze picture. Extraocular movement, as we see, there was a limitation of -5 in the left eye. Hirschberg test, there was a left eye exotropia of 45 degrees. Modified Krimsky test, there was a 80 PD base in for distance and 90 PD for near. Left eye was suppressed on TNO and there was no nil rheopsis on TNO. There was a lateral gaze incompetence which was seen. The measurements of exotropia was more in the right gaze because the medial rectus was not functioning, as we see here. Force reduction test was negative for the lateral rectus muscle in the left eye. Active force generation test, there was no tug felt for the medial rectus muscle in the left eye. MRI was done and we found that there was an increased distance of the medial rectus muscle which was still attached, as we can see in the MRI with the red arrow here. So diagnosis of left eye, consecutive exotropia, secondary to query medial rectus muscle slip with amblyopia was made, and a surgical plan of left eye medial rectus exploration with advancement was made. If the medial rectus muscle was not found, a left eye modified Nishida 2MR with lateral rectus recession was planned. So this is the surgical video. A Schwann incision was taken over the medial rectus muscle incision. So we found a stretch scar which was attached at a distance of 10 mm from the limbus, which was further dissected to found this bulky medial rectus muscle which was attached further 10 mm behind this attachment of stretch scar. So it was 20 mm from the limbus, which was then secured using double arm 60 vicryl sutures with partial and full thickness bite at the superior and the inferior end of the medial rectus muscle. The stretch scar was then excised. The muscle was advanced at a distance of 5 mm from the limbus. Conjunctiva was closed using 80 vicryl sutures. So this was the post-operative picture of the patient. Patient had a good alignment. There was a residual exotropia of 10 PD base in. There was no lateral incomitance and palpable fissure height was within normal limit. So on literature review, there are various studies which have been published on consecutive exotropia with medial rectus slippage, and it has been found that medial rectus advancement to the original insertion have given good results in these cases. So it is important to differentiate slip muscle from the lost muscle. Slip muscle, the muscle protective sheath capsule remains attached to the eye. The actual muscle fibers and the tendons slip out of the sheath and retract posteriorly. Sutures have passed alone through the capsule. This can be one cause. Not incorporating the muscle fibers or patient rubbing excessively postoperatively can be a cause of slip muscle. Lost muscle, the entire muscle including the capsule detaches from the eye and it retracts into the orbit with no part of it remaining connected to the eye surface. It can be because of trauma as a complication of orbital or paranasal sinus surgery or retinal detachment or strabismus surgery. In a slip muscle, the muscle is still attached within its capsule but it moves backward, whereas in a lost muscle, the entire muscle and the capsule have detached and moves away. So it is very important to know that this is a known complication of strabismus surgery which has been reported in literature, and it is important to do a thorough clinical evaluation along with imaging in such cases with suspected medial rectus slip before any intervention. Meticulous dissection following exploration, look for clues, reattach the medial rectus muscle. Though challenging, it's the preferred alternative whenever it is possible. Thank you.
Thank you, Dr. Salma. A very interesting case. And to get the medial rectus, the stretch scar is very interesting.
Good morning, everyone. Today I'll be presenting a case of complex strabismus under the guidance of Dr. Anamika Agrawal ma'am. The objectives of my presentation are to evaluate the clinical presentation of strabismus in a young female, to interpret the associated findings with the help of cover test and prism bar cover test, to elicit the importance of extraocular movements, and to discuss the rationale behind the surgical plan. This is a 19-year-old female who came to our OPD with complaints of constant deviation of eyes since childhood. This deviation was constant with no history of diplopia. There was no history of trauma, fever, or convulsion, no prior treatment with patching or spectacle use, and no history of any other ocular disease or any ocular surgeries in past. On general examination, the patient was within normal limit, the past history was non-contributory, and there was no family history of strabismus or any other ocular diseases. Coming to the ocular examination, the best corrected visual acuity in both eyes was 6/6. On Hirschberg test, there was 45-degree exotropia in left eye with right eye hypertropia. Cover test revealed inward movement of eyes with downward movement of both eyes, suggesting of dissociated vertical deviation. On alternate cover test, there was alternate exotropia, wherein the left eye did not maintain fixation and the right eye maintained fixation. We performed prism bar cover test, and it was found that there was 35 prism diopter. There was 35 prism diopter exotropia in left eye, which was performed by placing a 35 diopter prism in front of the left eye with base in. The vertical component in right eye was neutralized by placing a 16 diopter prism in front of right eye with base down, and the vertical component in left eye was neutralized by placing a 10 diopter prism in front of left eye with base down. The exotropia for up gaze and primary gaze was 35 prism diopter, whereas for down gaze it was 60 prism diopter, suggesting A pattern exotropia. The exotropia was equal for distance and near, and in levoversion and dextroversion. Coming to the extraocular movements, the ductions were full range in both eyes. On versions, there was excessive depression of both eyes in adduction. As we can see in this picture, on dextro elevation and levo elevation, there is limited elevation in adduction, whereas elevation is preserved in abduction. And in dextro depression and levo depression, there is excessive depression in adduction, which is pathognomic of superior oblique overaction. This depression was more in left eye than right eye. The sensory examination was carried out before other examinations. On Worth-4 test, there was suppression of left eye, which was suggestive of long-standing sensory adaptation. The stereopsis was reduced to 800 seconds of arc, which suggested poor binocularity. On summarizing, our diagnosis is 35 prism diopter A pattern exotropia with bilateral dissociated vertical deviation more prominent in right eye, with superior oblique overaction, with left eye astigmatism. These findings suggested multi-muscle surgical approach. Therefore, our planned surgical management was, for exotropia, we went ahead with left eye lateral rectus recession and medial rectus resection. For dissociated vertical deviation, we went ahead with both eyes inferior oblique recession. For superior oblique overaction, we went ahead with both eyes posterior tinectomy of superior oblique muscle. At 1 month follow-up, there was significant improvement in alignment. In conclusion, it is very essential to carry out a detailed squint evaluation using cover test, prism bar cover test, and careful documentation of extraocular movements to systematically arrive at a diagnosis and to facilitate proper management of the patient. Thank you.
A very good morning to one and all present here. I am Dr. Divya Chandwani, junior resident from D.Y. Patil Hospital, Navi Mumbai. I am presenting a case of monorectus transposition, paving the future in monocular elevation deficiency. I am presenting a case of 4-year-old male child who had come with complaint of drooping of left eye since childhood and decrease in left eye vision, as the child did not have central, steady and maintained vision. There was no significant birth history. On cycloplegic refraction, right eye was plus 3.25 diopter spherical and minus 1.75 cylinder at 172 degree, and left eye showed plus 3 diopter spherical and minus 1.75 diopter cylindrical at 9 degree. On extraocular movement examination, left eye showed minus 3 limitation in upgaze, adduction and abduction, and right eye were full and free. Pupils were central, circular and reactive to light in both the eyes. On modified Krimsky test of left eye, it showed 40 prism diopter hypotropia with 35 prism diopter exotropia. As we can see in this figure, severe ptosis, which was obscuring the visual axis along with absent lid crease, was noticed in left eye, and MRD was -1 along with poor Bell's reflex. Anterior and posterior segment were within normal limit. So based on these findings, we came to a diagnosis of congenital severe monocular elevation deficit with moderate amblyopia and severe ptosis. For this patient, we had done FDT, forced duction test for inferior rectus, which was positive. So inferior rectus recession was of 5.5 mm was done, which was followed by NAPS procedure or monorectus transposition with Foster augmentation. Post-operatively, ptosis was still present along with exodeviation. Patient who later underwent a surgery for ptosis correction and was advised patching to counter the amblyopia. What is monocular elevation deficit? It is an inability to elevate one eye in both adduction and abduction. It leads to hypotropia and may be associated with true or pseudotosis. It could either be congenital or acquired. Congenital causes are sporadic developmental abnormalities of neural or muscular pathways, and acquired could be due to trauma, vascular lesions like stroke, hypertension, or infections. Mechanism can either be paralysis of the muscle like superior rectus or the inferior rectus restriction, or supranuclear lesions which affects the upgaze pathway. There are 3 types of monocular elevation deficit. Type 1, in which inferior rectus restriction is there, forced duction test is positive along with poor Bell's phenomena, and normal upsuckers are restricted. Type 2 is superior rectus palsy, in which forced duction test is negative along with slow upsuckers above and below midline and absent Bell's phenomena. Type 3 is the supranuclear type, in which the forced duction test is normal along with absent upsuckers above the midline, and the type 3 is usually congenital. Clinical feature: patient usually presents with diplopia, inability to elevate eye, chin elevation, and a drooping of eyelid, and the signs are hypotropy of affected eye, hypertrophy of contralateral eye on fixation, true or pseudotosis, and absent Bell's phenomena, and amblyopia. For diagnosis, we can do forced duction test, active force generation test, Wirth 4-dot test, and MRI or MRI orbit and brain. So in this case, for management, we can either proceed with non-surgical like corrective refractive error, or treat amblyopia and prisms for mild deviation. And the main goal here is to improve primary gaze elevation, expand binocular field, and correct head posture. The common surgical procedures which can be done are NAPS procedure, in which we transpose medial rectus and lateral rectus to SR insertion, superior rectus insertion. Modified or augmented NAPS, this is a NAPS procedure along with a fixation, posterior fixation. Third is modified Nishida's procedure. It is a no tenotomy procedure, in which the muscle belly transposition is done. In this, there is low risk of anterior segment. There is low risk of anterior segment ischemia. Contralateral SR resection can also be done for persistent hypotropia post IR surgery. This is a flowchart showing the management of monocular elevation deficit. Monorectus transposition with Foster augmentation. Monorectus transposition is a good alternative to manage this case as compared to NAPS or Nishida's procedure, because of the following reason. A horizontal rectus muscle is available to tackle concomitant horizontal deviation, lesser chances of anterior segment ischemia, and one setting surgery as opposed to the multiple surgeries. Thank you.
Very good. One thing better you have to check in this is Marcus gun jaw winking phenomena also in a patient with MED, although this patient didn't seem to have. One thing you need to notice. Any other comments by the panelists for this case?
very good case presentation. In such cases, one should differentiate whether ptosis is a true ptosis or a pseudoptosis or a combination of both. The way to differentiate is to occlude the good eye and force the child to fixate with the paratic eye and then measure the ptosis. That is a true ptosis. Okay. And never to do the ptosis surgery in the same sitting as your squint surgery, because the position of the upper lid is determined in the ptosis surgery by the position of the upper limbus. And that obviously the position of upper limbus is going to change after the squint surgery. So you should always do a stage surgery with a minimum gap of 2 months between the ptosis surgery and a squint surgery.
Good morning, everyone. I am Dr. Chetna from JJ Hospital. The topic for my today's presentation is Duane's retraction syndrome. A 28-year-old male presented to the OPD with a face turned towards left and had a history of inward deviation of left eye since early childhood. Patient had no visual complaints or diplopia. There is no history of trauma, previous ocular surgery, or systemic neurological illness. On examination, we noticed face turned towards left, eyebrows at normal position, face is symmetrical, visual acuity in both eyes is 6/6 on distance as chart, and both eye fundus are within normal limits. This is a clinical picture of the patient showing first abnormal head posture, that is face is turned towards left. There is no head tilt or chin elevation or depression, and right eye ocular motility is within normal limit, but in left eye, on attempted adduction, we see a narrowing of palpebral fissure, and on abduction, there is marked limitation is noticed. Then we did squint evaluation, and on sensory examination, patient shows left eye suppression on Worth-Fodor test with corrected head posture and absent stereopsis using Titmus test. On motor examination, there is a 15 to 20 degree of left face turn is noted, and this is a 9 gaze photograph which shows patient is almost orthophoric in primary position with abnormal head posture, and there is abduction in there is limitation in abduction with widening of palpebral fissure, and there's near normal adduction with narrowing of palpebral fissure is noticed. No upshoot downshoot movements are noted, and there is no globe retraction or adduction. On prism bar cover test, there is 22 prism diopter of esotropy and primary deviation, and 30 prism diopter of esotropy and secondary deviation. So I came to a diagnosis of type 1 esotropic Duane syndrome of left eye with abnormal head posture. Now, what exactly is Duane's retraction syndrome? It comes under the broad spectrum of congenital cranial disinnervation syndrome, consisting of congenital misfiring of medial and lateral rectus muscles, characterized by limited horizontal eye movement, globe retraction, narrowing of palpebral fissure, and upshoot downshoot movements are seen on attempted adduction. So it basically consists of two pathologies, myogenic due to mechanical fibrosis of muscle, and neurogenic due to absence of cranial nerve nuclei or hypoplastic sixth cranial nerve due to disturbance in embryologic development along with anomalous innervation to the left to the lateral rectus via aberrant nerve of inferior division of the third nerve. Now, what is the mechanism behind globe retraction and upshoot downshoot movements? Globe retraction is due to co-contraction theory, and upshoot downshoot movements are due to leash effect of lateral rectus, and maybe due to anomalous paradoxical innervation to vertical recti. There is a Hoover's classification for Duane's retraction syndrome based on the innervational abnormalities. It is of 3 types, and they have a characteristic face turn. Like in type 1, there is ipsilateral face turn, and type 2 contralateral face turn is there. Then in type 1 is due to lack of innervation to lateral rectus. Hence, there is limitation in abduction and narrowing of palpebral fissure on attempted adduction. In type 2, innervation to lateral rectus is present, hence abduction is normal, but on attempted adduction due to co-contraction theory and leash effect of lateral rectus, we see overshoot movements. In type 3, both MR and LR innervations are present. Hence, in primary position only, we see retraction of the globe, and there is abduction and adduction, both are limited. Then differential diagnosis can be congenital restrictive squint, Brown syndrome, Mobius syndrome, strabismus fixus, congenital fibrosis of extraocular muscles, and synergistic divergence. Then management in milder cases we usually observe, and management depends on primary position deviation, degree of abnormal head posture, severity of globe retraction and overshoots, degree of limitation of ductions. And goals of surgical management are to improve the abnormal head posture and improve globe retraction and maintain the binocular single vision. This is an algorithm plan for ESO-DRS. In case of unilateral with minimal co-contractions, depend on the angle of deviation. If less than 20, we go for MR recession as per FTD. If more than 20, we go for asymmetric MR recession. And in case of severe co-contractions, we do MR along with LR and plus minus Y slit depending on the presence of overshoot actions. This is an example of large angle esotropia, more than 20 prism diopter, and patient needs both eye MR recession, and larger recession is done in the contralateral eye, as MR should not exceed 6 mm. This is an algorithm plan for EXO-DRS. It depends on the LR activity in abduction. If it is normal, then we go for LR recession and plus minus Y slit if overshoots are present, and if LR activity is absent, then LR periosteal fixation with supramaximal recession. Now, how does Y split help? Eye flip due to muscle slip, as it is depicted in the left corner of the image, that due to slippage of lateral rectus over the globe, there is upshoot movement is noted. So by doing Y split, the net vector of force acts only on the horizontal plane, and hence correcting the overshoot actions. This is an algorithm for ortho-DRS. If it is associated with some characters like overshoots or retraction, then we go for the surgery. If not, then no intervention is needed. And as as previously I said, if overshoots are present, then we go for Y slit. If retraction is present, then we go for asymmetric MR and LR recession, also along with LR recession in the same eye. These are my references, I'm sure.
Good morning, everyone. I'm Dr. Tanushri from Sir JJ Group of Hospitals. A special thanks to my professors and consultants at my institute for their immense support and guidance. I will be presenting on a case, a tilted view, unmasking superior oblique palsy. My case was a 23-year-old male who presented to our OPD with complaint of left eye upward deviation since childhood and intermittent diplopia since few months. He had no history of trauma, no history of eye patching or prism use in childhood, no systemic illness or past surgeries. He had no birth or family history. On examining our patient, there was both eyes anterior segment were within normal limits with a best corrected visual acuity of 6/6 and N6. Patient had entered our OPD with a right-sided head tilt, right-sided face hypoplasia, and slight chin depression. On Worth 4-dot test, there was significant diplopia, as the patient noted 2 red and 3 green dots. Stereopsis was absent in the patient as checked on Titmus fly test. On motor evaluation, there was a 5-degree right-sided head tilt. Hirschberg showed a 30-degree left eye head hypertropia. Double Maddox rod test showed no torsion in either of the eyes. Extraocular movements were full and free in the right eye, but the left eye showed over elevation in adduction, suggestive of IO overaction, and reduced depression in adduction, suggestive of superior oblique underaction. Prism bar cover test showed 30 degrees of left eye hypertropia in the primary gaze, which was increasing in right gaze and reducing in the left gaze. On tilting the head towards the left side, hypertropia was increasing, while on the right side, hypertropia was reducing. This is the 9-gaze image of my patient showing left eye hypertropia. Which was increasing on the right gaze and significant over elevation in dextroversion. This is the 5-degree head tilt of my patient. Indirect ophthalmoscopy revealed a normal fundus in both the eyes, but fundus photography showed left eye extorsion. So I conclude that mine was a case of congenital left eye superior oblique palsy. Moving forward to the case discussion, superior oblique muscle is the longest and the thinnest extraocular muscle, and hence it's prone to damage. The muscle fibers of superior oblique are at an angle of 54 degrees from the visual axis and attached posterolaterally on the globe behind the equator, hence providing it with the unique action of intorsion. Other actions are depression and abduction. It is supplied by the fourth cranial nerve, which is the trochlear nerve. Arising from the dorsal part of the midbrain, it has a very long course till it supplies the superior oblique muscle, and because of this long course and slenderness, it's very vulnerable to insult due to trauma or any ischemic damage. This is to clarify how the left eye movements were abnormal, while the left eye superior oblique was underacting. Its antagonist muscle, which is the left inferior oblique muscle, was overacting and hence justifying the over elevation in dextroversion left eye. Superior oblique palsy or the trochlear nerve palsy is most commonly congenital or idiopathic in nature. Acquired cases can be due to trauma, microvascular diseases like diabetes, hypertension, space-occupying lesion, or as a post-surgical complication. Patients usually present with hypertropia and extorsion in the affected eye, to compensate for which patient will keep their chin slightly down, head tilted towards the opposite side. Patient can complain of diplopia, which can be vertical or torsional, which worsens on looking down and in, like when the patient is reading. To evaluate such cases, we shall begin with a thorough history, old photographs of the patient, family album tomography, followed by a squint workup with cover test, Park 3-step test, Hess chart, diplopia charting, etc. Torsion can be checked by subjective means like double Maddox rod and synoptophore test, but they can a lot of times be unreliable, so we should do an objective test like fundus photography like we did in our case. Intraoperatively, we can do a oblique traction test to check for superior oblique muscle laxity. Systemic workup and neuroimaging are important in acquired cases, but not that much in congenital cases. To clinically diagnose a case of SO palsy, the two most important ocular tests are Belchowski and Park-Belchowski. Park-Belchowski test says that when you tilt the head of the patient towards the affected side, hypertropia is going to increase, and on tilting the head towards the normal side, hypertropia is going to reduce. Park-Belchowski is a 3-step test starting from determining which eye is hypertropic, and does the hypertropia increase on right gaze or left gaze, and then whether the hypertropia is increasing on tilting the head towards the right side or the left side. This is a simple case discussion showing right eye hypertropia in primary gaze, which is worsening on right-sided head tilt as well as on the contralateral gaze, which is the left gaze. So it's a case of right eye superior oblique palsy, also showing right eye extorsion in the fundus photography. Prism bar cover test will mostly show a V pattern. Patients can also present with bilateral palsies where hypertropia is going to be lesser, but the V pattern and extorsion is going to be much more. Differentials to my diagnosis can be ocular myasthenia, thyroid eye disease, blood fracture of lower bound syndrome, pseudoorbital tumor, etc. Management of SO palsy cases are mostly conservative, where we wait for 3 to 6 months, after which most patients resolve spontaneously. For congenital cases, we can try alternate eye patching or Fresnel prisms. Surgical intervention is usually required when the cases are persistent in acquired cases or in congenital cases, where we have a range of surgical options like strengthening the SO muscle by tendon tucking or muscle resection, weakening of the inferior oblique by resection myectomy. We can even operate on the contralateral eye based on the severity of the case, and that decision is made based on the modified NAP classification, which classifies patient based on their severity from class 1 to 7 and provides the surgical option. Like we did IO inferior oblique muscle resection in our case, as it was a class 1 type. Thank you.
Thank you. Over to Dr. Hardik for session 2.
The next presentation is going to be on resections and recessions. Probably the most fundamental thing that you'll need to keep in mind and learn. When we have our surgical hands-on, that's exactly how we are going to start, and now would be a good time to see how the real surgeries happen. Pick up the small nuances and Dr. Nidhi will guide you throughout.
So, my topic is relatively, I mean, it's easily the most common surgery you are all going to encounter in your career. Even if you, in your residency, if you choose to do squints, this is the most common surgery. I've tried to make it very simple to you. Let's begin with it. So, it's a simple recession and resection that we'll be practicing in the workshop as well. So, the first step of any squint surgery is to do a force duction test on table, which is generally done well when you have general anesthesia. Important thing to remember here is you have to hold the globe close to the limbus, as close to the limbus as possible, and you do not have to retropulse the globe. Do not push it inside the orbit, keep it loose, and you move the muscle along the arc of movement and judge the resistance that you are receiving. Now this is followed by, so we generally prefer a phonics based approach, but I have another video which shows you limbal. So we fixate the globe in the direction opposite to the muscle that needs to be operated. We incise the conjunctiva, make a small nick in the tenons thereafter, and expose the bare sclera. It is only once you see the bare sclera that you do the step number 3, which is hooking the muscle. So you hook the muscle, go along the surface of the globe and hook the muscle. So this is to orient you, this is the left eye of the patient that we are operating, the LR muscle that is being operated on, and this is where I am standing and this is where my assistant is standing. So we do surgeries here using surgical loop. Unless and until it's a complex case, we do not use microscopes at present. So this is the left eye and we've made a phonics incision. We have started hooking the muscle. We use the 12 mm hook first, followed by the 10 or 8 mm hook, to ensure the entire muscle is hooked. So once the muscle is hooked, this is another important step, that is isolating the muscle. You see the movement that I am making to remove the conjunctiva over the muscle. So it's not a swift, it's a sideways movement, like you are separating the conjunctiva from the underlying tenons and moving it away from the muscle. This is to prevent any conjunctival tear that may happen during the process. So once that is done, I am making a nick in the intermuscular septa and isolating the muscle. Now these are my 2 muscle hooks and the isolated muscle. I see the bare sclera here, the pole test. That means I've taken up all the fibers of the muscle. Now removing the anterior tenon capsule in front of the muscle. So thereby the entire muscle, and you see bare sclera on either side. So you're sure you've not missed any fiber of the muscle. Next is securing the muscle. First you take a central bite. So stopping here, you take a central bite, a partial thickness and a full thickness, and then bites on the either edges, same partial and full thickness. Now this is to prevent any complication of a slipped muscle that may happen thereafter. So this is a partial thickness bite that I have taken to the center. I generally take a larger central bite and then a full thickness bite. And at this stage you lock it. So the full thickness bite that you take, you always lock the bite. So I've locked this bite. Now I'll go to either of the edges of the muscle. Again, you take a partial thickness bite. And then a full thickness bite through the superior edge of the muscle. Now this is how I lock the bite. This is very important. Locking your full thickness bite is important. The same step I do on the other side. On the other side, I generally now prefer only a single full thickness bite, but you can take a partial thickness and a full thickness bite. Once your muscle is secured using your 6-0 vicryl suture, which is double armed, you can also use a single arm suture. You pass the sutures to your assistant who's holding the other hook so that you don't cut it inadvertently when you're disinserting the muscle. So here I've started disinserting the muscle. The moment I cut the inferior edge of the muscle, I use the Moody's to secure the insertion side so that it doesn't move. And then the other end of the muscle is also cut, again using a Moody's fixation forceps. Now this is a recession of a muscle. So what we do is we take a Barbie's forceps and then to expose the sclera properly, and also this gives a support to the globe so that when you're actually suturing, the globe does not move. So Barbie's does 2 functions. We take the measurement on a caliper. This is a very important step where you have to be careful. Now, if you see, you can just see the needle. It's not very superficial, it's not deep that you cannot see. And I'm going parallel to the surface of the globe. I'm not indenting the globe, I'm not doing anything. It's just a smooth movement in which I'm barely seeing the needle. And you come out at the other end. Doing a direct scleral fixation is much better. Sorry for the hanging that is happening in the video. So this is the most important step that you do in a squint surgery, is to do a scleral fixation and prevent any globe perforation at this time. You secure the muscle at the new site and then you cut the suture. The conjunctiva can either be closed using a 8 or vicryl suture, or it can be closed using fibrin glue. Here we use fibrin glue. So you use the 2 components of the fibrin glue and oppose the conjunctiva properly. So this is how we do a resection. Resection is similar. So the incision on the conjunctiva, the hooking of the muscle, the isolating of the muscle is the same in a recession and a resection. What differs is the steps that are coming forward. Is it too fast for the audience? So in a resection, what you do is you pass the suture away from the muscle insertion. So this caliper is the amount of resection I have planned for the patient. Suppose it's a 5 mm or a 6 mm resection. This caliper from the insertion to the amount, you mark it using caliper and pass your first suture at that level. And then one more important thing that I didn't mention in the recession video is that, if you can see now, yes. So if you see, this hand is actually holding a small hook and it's elevating the muscle from the globe. So this is basically, for me, when I pass the needle, I shouldn't perforate the sclera when passing. I should be passing it through the muscle. So it's very important to keep an instrument that elevates your muscle away from the sclera. So the step is the same. You have a central bite, which is partial and full thickness, and then followed by the bites on the edges. And once that is done, so usually before cutting the muscle, we use an artery forceps to clamp the muscle ahead of the sutures to prevent any bleeding. Once we clamp, we also use cautery to cauterize the blood vessels. And then we cut the muscle ahead of the sutures. So the segment that is there now between the cut end and the insertion, we cut it and cutting the muscle stump. This is a small hook retracting the conjunctiva to give a better visualization of the surgery. And we use a Moody's fixation forceps over here to stabilize our insertion site. Now once that is done, you can then insert the resected muscle at the insertion site. Again, be careful while passing sutures here. You have to ensure that you're not perforating the globe, because this is the only step in squint surgery where a patient's vision might get affected. Now, once you get the muscle near the insertion, your assistant can hold the suture to keep it in place, and then you cut the ends of the suture and you can close the conjunctiva. So now generally we've been moving towards doing fornix-based incisions, but I do have a case wherein I've shown a limbal surgery. We don't generally do limbus-based surgery now, unless and until it's a repeat case or if it's a complex case. This is a limbus-based surgery. It's one of the few limbus-based surgeries I have done. I tend to make an incision first parallel to the limbus and then make 2 radial incisions on either side of the muscle. You separate the conjunctiva from the Tenon's capsule, make an incision parallel, and then make 2 radial cuts on either side. So the advantage of a limbal incision is that it gives you very good exposure. Now I'm dissecting the intermuscular septa on either side of the muscle. So this patient was on blood thinners, hence this amount of bleeding. And you hook the muscle like you would in a fornix incision. So here I wasn't sure if I've hooked the entire muscle. Now I've taken a second hook and I've hooked the entire muscle. The remaining steps are the same. Just the incision differs. This is a good incision when you're beginning the surgery because you have a very good exposure of the muscle basically to understand the anatomy of the muscle. Then you can probably move to fornix based approach. Thank you.
Superior oblique is a relatively complicated muscle which we'll take up in the special surgeries section. Now we are just going to focus on mastering the inferior oblique. Half of my work has already been done by the residents themselves, so I'll just quickly skip through all these slides conveniently, just mentioning a few important points. Look at the insertion of the inferior oblique, look at the location of the macula, look at the location of the vortex vein. All three of them are in very close proximity. There are going to be times where you'll go close to the macula. Do not perforate. Make sure that the angle of needle is in your control all throughout. Bleeding of vortex vein is a dreaded complication, which, if time permits, we'll cover towards the end of the surgery. So this is the most important thing anatomically that you need to remember in surgery. Clinical wise, everything is covered. Inferior obliques, responsible for V patterns, DVDs. This is the spectrum of inferior oblique surgeries that is going to be covered. If when I was a DNB resident, my question was principles of inferior oblique weakening procedures, and just drawing this diagram can fetch you near total marks. Just make sure this is one thing that if you know, the whole spectrum of inferior oblique is covered. So now, my primary learning objective is going to be how to find the inferior oblique muscle, address the whole inferior oblique muscle belly, and insertion is probably the most simplest thing, because once you have disinserted inferior oblique, it's all a matter of where you place it. That is a part of the surgical plan. When to think about operating inferior oblique? For residents, probably this is one of the most important theory questions. The indications and the contraindications of operating inferior oblique, which we'll probably cover again when we are doing some hands-on. Let's start with the surgical video in interest of time. The most important thing is always stick to the basics. Never ever forget the FDT, FTT. See, the most important thing here is when you are doing an FTT, for inferior oblique, you have to press the globe down, because that's when the inferior oblique gets a little taut. Now, just to give you all an orientation, this is the lateral rectus muscle that is being hooked. This is the inferior rectus that is being hooked. The incision is generally about 8 to 10 millimeters from the limbus, and the inferior oblique muscle crosses obliquely. Once you insert your barbies, you can probably see some fibers of inferior oblique. Take your small hook and go in and get the inferior oblique out. The first challenge that you all will face is that there might be some hesitation as to how deep do I go? Will I hit the vortex vein or not? Remember, if your angle is correct, the vortex vein is far away. Once you have found the inferior oblique muscle, try and hook it, and the first thing to do is detach the attachment to the lateral rectus. Once the tenons has been detached, the whole inferior oblique acts like any other recti muscle with a very thick belly. The inferior oblique, for inferior oblique, the sutures have to be taken as close to the insertion as possible with the same suturing techniques that we had demonstrated for recessions and resections. There can be certain modifications to accommodate the bulk of inferior oblique, but the same techniques work. Once you have hooked the muscle, tagged the muscle, secured the muscle, you can safely go and cut. Remember, cutting is always towards the insertional site. Here is where the from the origin to the insertion, you have an intact arc of inferior oblique, and where you place this loose end of the inferior oblique is what determines what kind of effect the inferior oblique will give. Now, where do we attach inferior oblique is always a very important question. You need to have one anatomical landmark, and the nearest anatomical landmark is the insertion of the inferior rectus. Once you have hooked the insertion of inferior rectus, you know every single measurement around it. 2 mm behind, 3 mm behind, 2 mm lateral, 3 mm. So there are different points that are named across this bare area. You can insert it here, right next to the inferior oblique, slightly behind, 3 mm back, 2 mm lateral. And each point, let's say Sphinx point, will give you a different kind of recession effect. Recession for a recti muscle is just a simple weakening procedure. But in case of an oblique, it not just weakens the inferior oblique overaction, but also changes the direction in which the eye is going to move. So I hope that covers the basics of hooking the inferior oblique, understanding what is important. Next, let's move on to the inferior oblique anterior transposition. This is how the patient is being seated. We are operating on the right eye. All the videos that I have shown are in the same orientation so that everybody has the same picture. Inferior oblique is going to be this side, lateral rectus is going to be this side. Now in inferior oblique anterior transposition, you insert it right next to the insertion of the inferior rectus. Do you insert it along with the inferior rectus? No, because the scarring will cause some muscle fusion and the inferior rectus and inferior oblique might fuse. You should always leave a margin of around 1.5 to 2 mm from the lateral insertion of the inferior rectus, so that there are two muscles acting in the down vector. One is the inferior rectus and second is the inferior oblique, which is about 1.5 mm lateral to it. One important thing to remember here is an entity called as the J deformity. You'll always pass each edge of the inferior oblique, but they have to be at a slightly different level. If you insert it at the same level, especially if the lateral arc of inferior oblique is coming at the same level, it might induce something known as a J deformity, where a neurofibrovascular bundle gets stretched and might prevent the eye from going up. Inferior oblique anterior transposition, which is inserting it right next to the inferior rectus, is generally done in cases of DVD, so that it takes care of the vertical component to a certain extent as well. That's how we can make use of the muscle action being redirected into a different direction. Now, how do we assess recessions? This is entirely subjective as to how much clinical grade of recession should produce how much clinical grade of inferior oblique overaction demands the amount of IO recession. We will take inputs from our panelists as to how do they decide the dosage for inferior oblique recessions, but the technique here is more important. Even if you place it 2 mm, 3 mm, the effect might not change much, but remember that you have to place it along the arc of inferior oblique. The recessions are graded in a different way as well. Now, when you want to address the vertical component of the inferior oblique as well as handle recessions, there are different points that have been described in literature. Now, why are these points important? Let's say I want to do an inferior oblique recession of 8 mm. Now, imagine the arc of inferior oblique, insertion, go back 8 mm. So here is somewhere where you will get an inferior oblique recession. But this is an unreliable anatomical landmark to reliably get measurements here. There are points which have been described closer to the lateral end of inferior rectus. Let's say, for example, Park's point. You go 3 mm behind and 2 mm lateral will give you the same effect as a 10 mm recession. So this is what you need to remember as to if you're not doing a simple recession of 8, 9, 10, these are the points that you're supposed to look at. This is the AO guideline as to how much do we recess for different grades of inferior oblique overaction. And here is another surgical video describing the same thing. Now, please note that the steps of the surgery are going to remain exactly the same. Once you have recessed the muscle, made sure that it has been detached from the lateral rectus, hook your inferior oblique, get your anatomical landmark in place, and then place your sutures. Please note that after passing one suture, the muscle should come up. There is going to be some amount of bleeding because it's a bulky muscle. Make sure that your homeostasis is well taken care of. And the second bite that you pass through should not be at the same level, should be slightly inferior to the first one. Last but not the least is inferior oblique myectomy. Probably one of the most simple inferior oblique procedures that people do. The main advantage here is it saves on time because you don't have to take additional bites. Once you have hooked the inferior oblique, found the muscle belly, take a significant amount of muscle belly, approximately 8 to 10 mm, clamp it, avascularize it, cut the chunk, cauterize the ends of the inferior oblique, and just leave the inferior oblique. Now one question arises, what happens when we leave the inferior oblique? It will go attach somewhere down the line to the globe. But remember, since you have cut a big mass of inferior oblique, the attachment is going to be way posterior and will not give you a strong effect of inferior oblique in the first place. Now coming to the last bit of it, complications. Missed fibers, muscle tear, vortex vein bleed, anti-elevation syndrome, all of this is something which is very important to keep in mind, especially for the residents. If your viva reaches this stage, it means that you are doing really very well. Now this is one case where everything that could go wrong went wrong. You all can see that the inferior oblique muscle has been hooked, but let the camera stabilize a little. There are some fibers that have been missed. So once you know that there are some fibers which are missed, you have to go and chase those fibers. How do we know that some fibers are missed or not? So there is an entity called as the white triangle. You have to retract with the Barbies all the way and look if you can see the vortex vein. Everything till the vortex vein should appear white. If there is any pink or red mass, probably it's a muscle. You need to go back and rehook it. Now, here is where if you pull the muscle too tight, no matter how bulky the muscle might look, how strong it might look, there are always chances that if the assistant is a little too enthusiastic, you might have a muscle snap. The surgeon is trying to pass a muscle bite. The assistant is holding quite tightly, and now see what happens in the next 4 or 5 seconds. After the first bite is taken, the surgeon goes to take the second bite. The needle is being reloaded. Everything looks as if, okay, everything is under control. But the moment the needle touches, there is a muscle snap. I hope everybody caught that. I slowed it down to about 6 times so that everybody can get that. In such situations, do not panic. The first bite was taken, so there is some attachment of the muscle to the thread. Your thread tagging is the most important thing. As Sir had mentioned that once you get the MR, if it's tight, tag it first so that you have something to hold on to. An inferior oblique, after you have cut attachments to the lateral rectus, it can slip back and retract. In this case, we were lucky enough to go back, find the inferior oblique muscle, find the whole belly, and then convert it into a case of inferior oblique myectomy.
Most of it you have already mentioned, and it is the surgical anatomical landmarks which are very important. And of course, inferior oblique is something which is quite deep buried into your orbital area. So you need to actually kind of find it by putting the globe in that position or in the opposite direction. That is elevating or lifting the globe, and like Dr. Chandresh rightly mentioned, the globe is suspended. So you lift the globe and you put it into an adduction, so basically a levo elevation kind of position, so that the inferior oblique muscle rises up as it is passing underneath the inferior rectus. So there are multiple ways to do it. Surgeons do go blind also, because that is the anatomical location between the inferior rectus and the lateral rectus, and you can go with your muscle hook and lift the muscle. Very good way is to actually visualize the edge of the inferior oblique muscle and to hook it. Once you have hooked the muscle, and you have one of the important points here to mention is never dissect the tenons, because remember, when you cut the tenons here, you can have the orbital fat which is coming into. So it is likely to dissect the tenons. So nowhere you have to cut the tenons tissue. That is one, and specifically in elderlies, because it's very common to have the orbital fat to come into the subtenons area. lift the oblique muscle, look at the white triangle, which is a surgical triangle, look at the vortex vein. Then vortex vein need not be always at that 7 o'clock, 11 o'clock position, but you can see all the fibers come through. So you have to look both ways. Once you lift the muscle, you look underneath it and you look over it. And that pretty much sums up the entire belly. Remember that it does not have a tenderness insertion like all the recti muscle, it's belly throughout. So that way, yes, it's very common to split the muscle. And one of the commonest muscle to have anomalous insertions, dual insertions, is also inferior oblique. So remember, you can have a bifid head of inferior oblique also. So these are the things might common and missed also by a lot of us. So that are things to be paid attention to when you're hooking.
Thank you so much, Dr. Janil. So we already had a case presentation on Helveston's triad, which is A pattern XT DVD with superior oblique overaction. Now this is one of the cases that we had operated here. Now for residents, you'll have to get used to looking at these numbers. You can't always rely on the 9-gaze photographs because these numbers will give you more information than the 9-gaze photograph per se. Look at the primary gaze. Do you feel that this patient has a squint of around 65 PD? It does not seem like that. So until and unless you stick to your basics, follow your cover test, you will not be able to unmask these findings. Stick to the basics. Remember, always do an FTT. In this case, what we did was, since we are handling Helveston, we generally tend to address the superior rectus for the component of DVD rather than the inferior oblique. Once the superior rectus has been disinserted, you can go in, find the muscles which are always glistening, pass your small hook, insert the pass your Green's hook and make sure that the whole belly of superior oblique is, whole tendon of superior oblique is visualized. In this case, where we do a PTS, so that is posterior tenotomy of superior oblique, only the anterior 1/8 fiber was spared and the posterior 3/8 was cut. Now 3/8, 1/8, 7/8, these are subjective findings. The moral to take here is make sure that a thin strap of superior oblique is left. Why do we do that? Because the insertion of superior oblique is fan shaped. The anterior 1/3 and the posterior 2/3 have two different functions altogether. If you all remember the primary, secondary and tertiary action, we are addressing only the pattern part here. You should not induce a torsion while doing a superior oblique surgery. That's why it's mandatory to leave the anterior 1/8 or 3/8 part of the superior oblique.
So I'm going to present, this was my very first case. This was almost a 9 years old video of, this first day in my clinic, a child came to, I just joined as a junior ophthalmologist, a child came to my clinic in this way. And it was pretty evident, but yes, measurements are always tricky and what to do and which muscles to tackle, how many muscles to tackle. So this was a child who presented in this way with the right head tilt, very large and always in this position. The mother is concerned, and if you look at under the Spielman's occluder, this the fixing eye is the right eye, and the left eye you can see a large vertical deviation. Essentially a diagnosis of congenital fourth nerve palsy, and we did the Belchowski head tilt test. Everything came out to be pointing towards isolating the superior oblique, underacting of course congenital SO, and we tackled two muscles. I'm going to address only the superior oblique muscle here because the amount of deviation again is more than 35 prism diopters in the primary position in large head tilt. So your laxity of the muscle doing a FTT, and this is a very important, and you judge the laxity sometimes not only on FTT but when you hook the muscle, and there are ways to hook the muscle, and here you will see me a little bit of struggle of hooking the muscle and what all mistakes we made. But once you hook the muscle you get, and there is a typical namaste sign now described if you have come across literature where two tendons meet each other like a namaste fashion. And so yeah, this we are going to come across fornix based incision here again. I hooked the lateral rectus muscle. This video is going to be high speed. Now this is a very different kind of spatula. We still don't know what do we call it, but we call it as a superior oblique spatula. It's very different. It's not like your iris repositor. You can use a small hook also or a muscle hook also. Remember, these fibers are flushed. It has, unlike the inferior oblique, the superior oblique has a very large tendon, and it spans around 6 to 8 millimeter in the fan shape format. So you have to go as posterior as possible, and the biggest surgical anatomical landmark here, which if you see closely here, is the vortex vein. So you have to go as posterior, just anterior to the vortex vein is your last fibers, the posterior fibers of the superior oblique. So always hook the posterior superior oblique from posterior, otherwise you're going to split. What you see here is the split fiber. So I thought I will include them. What I am trying to do here is a superior oblique tuck, but here you can say it is a kind of a plication because I am more close to the insertion rather than going more. One of the trick of trade here is when you want to isolate the superior oblique, be along the course of the superior rectus. So isolate the superior temporal margin of the superior rectus, go as behind as possible. So here I have placed it on an adjustable, so not a sliding nose knot, but I placed it on an adjustable here where I am again revising because I checked my FTT. Now I just find it tight enough. The reason just find it tight enough is you want to convert your superior oblique palsy into a Brown's like picture, but not completely. So your eye is just able to move above the horizontal midline. So you have a Brown syndrome where there is a massive limitation in adduction in elevation. Here you want the globe to just move enough, so you have to judge based on your forced traction test that how much of tightness you are going to induce. Otherwise you will have a large undercorrection in this case, but I am combining it with the inferior oblique anterior transposition. This is a 2 muscle surgery for a large vertical deviation. Here we got the child is orthotropic in the primary position and his head posture has improved. I'm sorry for the slowness of this video, but he had a massive resolution of the head posture and the mother was quite happy in this case. So this was my earlier case. Your trick of the trade is that hook from posteriorly as posterior as possible. Make sure you have all the fibers and use a small hook. And if there is an SO tuck is, now the question is how much amount do you tuck? There are some guidelines, but it will come on the traction test. You have to put it on adjustable, check for the forced traction test. If you have induced the right amount of tightness to the superior oblique, again go and revise. It will come with time, but there are no, this what I did was 4 by 4 millimeters. So 8 millimeters of the tendon of the superior oblique, both anterior and posterior fibers were tucked. For this case, I was going for maximum for larger amount of deviation. And now next is another type of superior oblique surgeries. Now Brown syndrome, we came across, Dr. Harsha presented a case of Brown syndrome where there are multiple ways to do it. So essentially here it's exactly opposite. In superior oblique palsy, you want to strengthen the tendon. In Brown syndrome, you want to loosen it or weaken the tendon. So there are multiple ways to do it. You can do a complete tenotomy in cases where it is very tight. You can put a spacer to lengthen the tendon. So basically the tendon length is increased, or you do something called as a superior oblique lengthening by Z-plasty. Now Z-plasty is a procedure which is used by plastic surgeons in case of scar revising where you want to lengthen the area of the tissue. This child presented with such a horizontal and a vertical deviation both, and you can see a very typical Brown syndrome that she had a hypertropia in that eye with a large limitation in adduction. So what we chose is this. You can see the tightness, the globe barely moves, it's just above the, just going beyond with a lot of tightness actually. And remember when you are doing this forced traction test, if you are doing under anesthesia, of course for a child, while hooking the muscle, keep hearing the pulse of the child. You may notice that there is a bradycardia. So these are the things also to be kept in mind as a surgeon, and just don't rely on the anesthetist. So it's really important that you keep your eyes and ears open. Again, same, trying to go as posteriorly as possible to isolate the muscle. You can see this fan shaped here, thin glistening. And you may notice a different anatomy of superior oblique unlike the inferior oblique muscle. So you are able to hook it, make sure all the fibers are visible. Again, go as posteriorly as possible. Isolated it from the superior rectus. There are attachments between the intermuscular septum between the superior oblique and the superior rectus like this, and you isolate them so that it's quite free. And remember, always go along the course of the superior rectus to get the muscle. So now what I am doing it is I am trying to ascertain how much amount of Z-plasty I am going to do. This again is 4 by 4 millimeter. So it is like a Z shape. You go from here, form a Z, the longer arm of the Z is going go vertically and this way. So I am going to split the tendon into two and then attach it with itself, causing a lengthening effect. So this is the upper part. So this one segment of the tendon which goes towards the insertion, and this one segment of the tendon which goes towards this course of the, or goes towards the trochlea. So I am going to have now two tendons and then I am going to attach it. So now you have split it and reattached, lengthening the tendon, giving a lengthening effect. Again, there are nomograms for it applied by Barton, Kushner and other groups, but again this will come with judgment. Usually what I do is 3 by 3, 4 by 4 or even 6 by 6 in cases of how much amount of tightness is there. If it is very tight, then tenotomy is also one of the surgeries which is advisable in such cases. So now I am going to cut it. You have to be very good in the orientation of the muscle, because this is one arm. If you cut anywhere else, you will get a tenotomy. So you have one half of the muscle. Make sure the tenons is very well separated. And when you cut this half, so now you have got two segments of the superior oblique now, and now essentially you have lengthened by 8 millimeters. So it was attached with itself. So this is a Z technique, and you can see the FTT much free as compared to, you can see the movement of the globe much free. Of course now it's not attached. Once you attach it, you recheck it whether you have got the amount of laxity which you are looking for, because too much amount of lax, remember, you can induce a superior oblique palsy in these children also. So in this case there was a horizontal strabismus also performed along with this. I felt this is the right amount of traction test which I needed, and this child had a very good outcome. She was orthotropic, and look at the motility here, it's significantly improved as compared to the preoperative. So these are sums up most of the superior oblique surgeries. There is Haradayito, there is anterior transposition, you may do it, but we limited to these three surgeries, which are one of the commonly performed. And of course PTSO, that is the posterior tenectomy of superior oblique fiber, is one of the commonly performed superior oblique surgeries. It is not as forgiving as inferior oblique surgery. Remember, the patient can have intractable torsional diplopia, so be very careful while choosing the superior oblique muscle, and only when it is required touch the muscle, unlike the inferior oblique, which is very forgiving in many cases.
Thank you so much, Dr. Chanel. We will take one last surgical video for the VAST session, and that will be by Dr. Nidhi.
Sorry, in interest of time, I have a true muscle transplant video. For those who are interested, I can show it later. But let's go to the adjustable squint surgery. So what technique I use here is a sliding nose. This is a case of a thyroid eye disease patient who was managed during her active inflammation, and once the inflammation subsided, she had a restrictive strabismus. So this is the technique of doing a sliding nose. So you disinsert the muscle like in a regular squint surgery. This is what I have done here. But now instead of passing a regular direct scleral bite, what you do is a cross sword technique of inserting the muscle into the muscle stump. So this is what you're supposed to do. Of course, I have passed one suture and then I have passed the other suture, but they're both crossing each other. So this is a cross sword technique, a slightly modified form. Once you're done with that, now the amount of recession you want to do on the muscle, you measure it on a caliper. At this point, your assistant will hold the suture at the mark that you want to do the recession, and then you will tie 2 or 3 knots on this suture. This is your pole suture basically. This is your main suture that is holding the muscle. Now once that is done, you have to make a sliding nose. So you take another suture, it need not be with a needle. You pass it in a loop around your pole suture like in the way shown here, and then you tie knots. This is the second knot I am tying, and then I am trying to move the nose on the pole suture to make sure it's loose enough for me to adjust later, and it's tight enough for the muscle not to slip more than what I desire. So now after that is done, now this patient was under general anesthesia. So this is the pole suture. One trick of the trade here is how do you differentiate when you're adjusting. You have 2 sets of sutures. You have a sliding nose and you have a main pole suture. So your pole suture or one of the sutures you can keep longer, and your adjustable suture ends you can keep it shorter, so that when you reopen the same incision site, you know which suture you are holding. Are you holding the one with the longer end, or are you holding the one with the shorter end? So this patient, after recovery from general anesthesia, she had a bit of a residual esotropia, so for which I had then adjusted her on the very same day. So you tuck in this pole suture and the sliding nose, and you suture the conjunctiva like in a normal squint surgery. And after the patient has recovered and you are able to do a cover test, and if you feel there is a residual, you can go back in, but this time you don't need to give GA to the patient. You can do it under topical anesthesia. We don't do adjustment in OPD, we do it in OR. And you remove your pole suture, you remove your sliding nose, and if you want to increase your recession, you move the sliding nose towards the pole suture. Measure it and then again reposit the muscle back. And you can close the conjunctiva thereafter. Usually I use sutures for these cases. You just have to make sure your suture and your knots are buried into the conjunctiva, because there are 2 sets of knots here. That's it. Anyone interested in muscle transplant, I can show it later.